What is up? This is John Nelson, and you are listening to the Starting Block Podcast. We are a podcast for complete athletic development, and our mission is to give you the tools to win, whether you are the athlete, the parent, or the coach. Our objective is to give you the tools to win based on the experiences that myself and my co-host, what's up, Chris?
What's up?
And Mandy have through all our years in this industry. We want to give you guys the tools to win. So if you're new to our show, welcome aboard. Thanks for joining us. We run our show a little bit differently than most podcasts. So the first type of episode that we have is going to be a Q&A. And this Q&A is our most frequent one. This is where we take questions from you guys that y'all submit to either our social media pages or to info@elitelevelperformance.com. And we answer those questions on the air for you. Me, Chris, Mandy. Mandy's not with us today, but she's on most episodes. And we'll answer those and dig deep into them and give you as much insight as we can. The second type of episode that we have is a guest interview. And the guest interview is going to be where we bring on our colleagues from across the country, across the globe, and they're going to share their stories of success, how they win, whether they are in the healthcare field, whether they are trainers, coaches, business owners, whatever. They're going to share their secrets of success, what they do to win, and how they help their clients win as well. And then the final type of episode is our Friday Fire episode. That is where I do a solo cast, and I will share 10, 15 minutes of my inner dialogue and what's going on in my head. Usually it's going to be about leadership or something along those lines, and or on a social issue I feel like we need to discuss a little bit, and those are Friday Fire. So today's episode, as you know from reading the title, today's episode is a Q&A. Now, we normally take 3 or 4 questions, sometimes 4, usually 2 or 3 actually, and we'll break them down, but I felt like this question, Chris and I discussed this before the show, we felt like this question was very relevant and is probably worthy of its own episode. And this question submitted by Austin, thank you, sir. And the question was, what is the difference between what you guys do and PT or physical therapy? And so I think what he's asking is what's the difference between using the newbie, the activations, the systems that we use versus traditional therapies. Specifically said PT, but I guess you could include other types of therapies that are out there. There's all kinds of stuff, Rolfing, chiropractic, et cetera, et cetera. And so, yeah, it's a very good question, very good, and one that really we should dig into. So, yeah, Chris, why don't you get started, man? Where do you want to start here?
Well, yeah, it's a very good question. So, I've done my share of work in the physical therapy field. So this is... Yeah,
and guys, and I'm going to interrupt Chris because he won't say it, but Chris is a humble guy. He won't say it, but understand, guys, that Chris was a former licensed PT, so he's got that education. He's been in that field as well. And that's something that, we appreciate and respect. He's got an education, previous license, so... That's something you probably didn't know about Chris, and he probably wouldn't share. So I did for you.
Right. Yeah. And what's interesting is, now keep in mind, the way I'm going to answer this question is based on my experience with PT and not with anybody else's. Because let's take the approach that you take, John. Could a physical therapist go learn a lot of the same techniques and go get newbies and learn 100%. How to... Absolutely they could.
Oh yeah.
And and probably would help their outcomes.
Oh yeah.
But we're talking about the way it's typically done. So for every one therapist out there that's doing just a fantastic, crazy good job, there's probably 10 who are out there doing a very standardized job. Maybe more than that. I don't really know. I've never counted. But so let's address it this way. Typically, let's just say, and by the way, since this is primarily an athletic-based podcast, I'm going to use that as an example, more of an athletic or an active adult from the perspective of someone coming from this arena. So the person's most likely very motivated to get better. if you're an athlete, if you're an active adult, you want to get back into the game. You don't want to be, sitting on your butt doing nothing. You're motivated to get better. You just want to be able to do it without hurting, or you want to be able to do it without having, symptoms of some sort. So that's half the battle right there. Oftentimes when you go into a standardized physical therapy clinic, a lot of your patient population, as crazy as it sounds, may not want to improve. They have no real motivation. So that's now on the patient's end. If you want to improve, that's half the battle. So if you have half your patients that really don't care about improving, well, that's going to reduce your outcomes right there.
Yeah, it makes success a little harder. Yeah.
Absolutely. So secondly, you and I have discussed a lot on we're beginning to see things on the neural input end of things. Mm-hmm. And I've got to bring up definitely two specific experiences that I cannot unsee. All right. So coming from the physical therapy world, you would see someone with a sprained ankle, and this particular person I witnessed being treated by Dr. John Pietola, okay, your mentor, and certainly someone that I know fairly well. I witnessed him working with someone that came in sprained ankle. The way he systematically began to, address not just the issue with her ankle, but quickly found out she also had a problem with her right shoulder. Okay, she comes in with a left ankle problem, also finds out there's a right shoulder issue. Yeah. Addresses all of those things, and this person in one treatment walks out better. And by the way, it was a Dr. J treatment followed by an ARP wave. Okay, ARP wave treatment using what is now as Garrett Salpeter would call it, the foot bath. Again, someone with a sprained ankle. I had never seen anything like that before. That would have never been done in the clinic I had worked in. And she walks out in one treatment much better than she walked in. Now, she wasn't 100%, but there was a significant improvement. I can't unsee that.
Major improvement.
Yes. Yeah. The other big, and again, was how much physical therapy did she receive? 0. There was not a physical therapist in that room. There was a chiropractor who was leading the treatment, and then whoever was doing the ARP treatment after that, that Dr. J prescribed, there was no physical therapy. And yet she walks out better than anybody I'd ever seen come in with a grade 2 ankle sprain. In addition, treated the shoulder that they didn't even know was a problem. She wasn't even in there for that reason.
And to interrupt you, just because for us, Chris, like this conversation, I mean, this is standard in our experience at this point in our careers. Like we see this, but I think for the general public or the high school kid who's listening to this and doesn't quite understand the significance of that, like when you say a grade 2 ankle sprain, kind of share that a little bit from your perspective. Like what is your typical time frame and, doctor prescription and like 6 to 8 weeks, non-weight bearing, like what, can you explain that a little?
Yeah, typically, grade 2 ankle sprain can vary a little bit from prescription to prescription. And keep in mind, it's not like there's not just an absolute pure definition of a grade 1 versus a 2 versus a 3, other than to say a 3 is supposed to have like complete tears of the ligament and whatever. Grade 2 is, some tearing of the ligaments, but not torn. Grade 1 is typically maybe some light swelling, probably little to no discoloration, and just, they're hobbling around a little bit, and they're usually fine with or without any treatment, okay? So a grade 2, you did a little bit of damage there, guys. Yeah. So just understand the significance of that if you're trying to follow kind of what a grade 1, 2, and 3 means. I mean, grade 2, you did some damage there. Some tissue
so somebody to make that type of improvement in one session is pretty dang
Right,
impressive.
pretty significant. So what did Dr. J do differently? Well, he addressed the neural input. He tries to reduce the threat of this person coming in, putting weight on the ankle, and so on and so forth. What then the follow-up treatment with in this case, the ARP, further reduces inflammation in that ankle by helping the muscles around it absorb forces better, and you probably have, y'all might even do the foot bath there. Pretty.
Oh gosh,
So
I love the foot
yeah,
bath.
so it's
great.
It's like you see her toes curl up, with and it's really it's the first time I'd ever witnessed that. And it was really cool looking, kind of funny looking, and yet it was very eye opening, for me.
Mm-hmm. It's always very questionable when you add electricity.
Yes,
and
it
water,
does. Yes.
and I always make sure, because you always see the look on the person's face. They're like,
really?
Is this okay? And it's like, yes, this is okay. Please do not go in your bathtub and take your hairdryer or something with you. That would not be
exactly.
good. So it's a little bit different, yeah.
So it is pretty interesting to watch that, but once again, I mean, so what are you doing? You're addressing the neural input, followed by reducing inflammation, followed by and also getting the muscles to absorb forces better. You have someone who is instantly better. Now, I say instantly better, not instantly 100%.
No,
but we're talking about the same practice that got Dwight Freeney from a grade 3 ankle sprain to play in the Super Bowl, whatever year that was.
I forgot all about that one.
What was that? Colt.
I used to use that one a long time ago. But I forgot about that.
Yeah, that was a grade 3, and that was 1 week later, I want to say, or was it 2 weeks later? I mean, that was unheard of. But
there used to be video of him of that on YouTube. I think they
took
it down.
Yes.
Huh?
So it was that was a grade 3 ankle sprain. That was anyway. That's just a story that you can use to sort of follow up. But so naturally, someone has a lesser injury, you're going to notice even a quicker result. So the second one was, by the way, someone with the same last name as you, John. I think his name was Tom Nelson. He was hosted a Be Activated clinic in Chicago, Illinois area. Chris Corfist was one of the hosts. Dan Fichter was one of the hosts, and Dr. Nelson. It was actually in his office. And
by the way, a sneak peek, if anybody is listening, Dan Fichter will be joining us here in a couple
yes,
of
he will.
So
absolutely. And anyway, so Dr. Nelson himself had
was Dr. Nelson, was he one of the gate guys?
No, that's that is those are two. I think they're podiatrists. This was a primary care physician, I believe. I think.
I feel I know that name for some reason, but I don't know why.
Well, he pretty much, after this clinic, he pretty much changed his whole practice. He was your standard, I think, medical practitioner in that he saw a lot of typical well visits and just general patient population in this clinic until he did Be Activated. Well, Dr. Nelson, years prior to hosting this clinic, I can't remember how he ended up with such a range of motion issue in his shoulder, but I want to say he probably had 110 degrees of shoulder flexion. Okay, if he were to hold his arm straight at his elbow, he probably could barely get his hand higher than the top of his head, barely. You should be able to raise your bicep up to your ear. Well, I want to say that this had happened years. I want to say he was like a teenager whenever he hurt his shoulder. So this was a 20, 30 year prior injury. In 10 minutes of this RPR or this Be Activated, he's able to pretty much flex that shoulder all the way up. I mean, it was 160 plus degrees. So from 110 to about 160 in 10 minutes. And this is not a new, fresh injury. Okay, there's the practitioner did not touch his shoulder, did not touch his arm. He did the Be Activated technique. And now all of a sudden, Dr. Tom is able to raise an arm much closer to full range of motion, again, in 10 minutes. Now, once again, that's something you can't unsee. I can't deny it worked. Okay, did it make any sense to me at the time? Absolutely not. But I can't deny it worked. He can't deny it worked. He absolutely changed the way he practiced medicine at that point. The last thing, and by the way, I was trained in that technique by a physical therapist. I could not use it in a physical therapy clinic. I was not allowed. All right.
Yeah.
I was not. I'm not saying that nobody could. I'm saying I could not, where I was working at the time. Third and final story along that line. You have some familiarity, John, with primal, what's it called? Yes, primal reflex release. Once again, trained by a physical therapist. The most gentle techniques you could ever find anywhere. Very gentle. Oh, yeah. And when it works great. When it doesn't work, it doesn't work. No, it's not. Primal reflex release technique is not something that you can use on someone with a true injury. Like, it's not going to help. It's not.
Right.
But if someone has just guarding and tightness and pain with movement, but there's no diagnosed like fracture or tear or whatever, it works great.
I mean, it works. It evaluates nociceptive responses, which you can say a fancy word for trigger point, so to speak. And they're just protective mechanisms. And like, if you're a coach listening to this and you don't utilize that, you need to, because it's a great tool to have in the tool bag for sure. Shoot, I remember I used it doing Tough Mudder once.
Yeah,
we were doing Tough Mudder, and there was a guy cramping up, and that was one of the things I did to him. They're like, "What are you doing?" I'm like, he's fine. And all of a sudden, he can walk again.
Yeah, it's nothing to it.
But it's a great tool. I would. Is Dr. Imes? No. Sorry to interrupt you, but is Dr. Imes still around?
I think so, but I don't know. I really don't know.
He really brilliant. Was. His work was awesome. Like, and you and I barely scratched the surface of it. I don't think. I mean, I think we had a couple courses that we went through, but. Man, I love that stuff, and I think Dan. I think you and Dan are the one that.
Yeah, it's simple. Yeah, it's not. I mean, it's very simple.
Oh gosh,
and it's and yet again, I use it, go to use it in the clinic, and I'm not allowed to, and I'm like, well, what can I do? Yeah, I don't. So once again, this is not physical therapists, because I learned these techniques from physical therapists who were clearly getting great results with using simple techniques. It was the way physical therapy, the practice, was practiced where I was. Does that make sense? So, So kind of back to Austin's question. Is there a difference? The way I practiced it or the way that I was told to practice it? Absolutely. Because what if somebody has bad wiring? Okay, their brain cannot break this compensation pattern, a bad movement pattern. They need to have the software. They need a software upgrade or a software adjustment before they can get any benefit from this exercise that they're doing. Well, you're beginning to see now. And actually, it's non-physical therapy that's taking the charge, that they are beginning to say, look, let's address the input, the neural input first. Then we can go and actually do the exercise and get some benefit. All right? We can actually strengthen this tissue or strengthen these muscles that are surrounding this weak tissue or this injured tissue or this damaged tissue. It's got to be, let's address the brain first. Then we can get the benefit of what we're trying to get, as opposed to just trying to hammer this exercise, trying to hammer the strength training that may or may not be doing this patient any good. That's where I would say the way my experience has been in the way it's practiced. There has never been an addressing of the neural input end of things. That's what you're seeing the square ones of the world addressing. That's what you're seeing Dr. Matt Boulay. That's what you're seeing posturology. That's what you're seeing him address. That's what you're seeing. Dr. John Pietola. That's what you've seen him address now for years. I mean, he was the first one. He's that example of the first one.
Yeah.
That first example we gave. That's what you're seeing. The John Iams. Again, some of these are physical therapists. That's what you're seeing them address. The software before you address the hardware. They seem, in my experience, they seem to be getting results where a lot of times traditional physical therapy has failed because they keep trying to hit the hammer with the nail or hit the nail with the hammer, and they just keep freaking missing. And, eventually you got to try something different. And I think that's where I've often seen the hesitation is in, okay, we keep trying to do this, again and again and again and expecting a different result. Chances are it ain't happening. Try something different. Let's try the input first. And I think that's where the way you've done things, that's the way I'm learning to do things. That's the difference.
Yeah, and I think that you're starting to see a little bit of shift, in I don't want to say medicine or healthcare, but you're just seeing a shift in the spectrum of everything, strength and conditioning, fitness, and healthcare, and into an openness of, okay, there's increased rates of, my gosh, it seems like everything these days. I mean, youth injuries and whatever else. I don't have any numbers in front of me, but I mean, we can all probably attest to that. I mean, that probably increases in orthopedic issues, increases in youth sports injuries. I mean, just the explosion of Tommy John, over the last 10 years or so, and I think you're starting to see a shift in, I'd say, our community as far as healthcare providers and us and everybody, that there are other things out there that are that can be of benefit, because if some of these elements were the end all be all, then we probably wouldn't have some of the scenarios that are going on. And that's kind of one of the things that I talk about when somebody calls or comes in for a new appointment is, I tell everybody right on the front end, look, I'm not a doctor and I'm not a physical therapist. Like, my job is not to treat or diagnose. That's not what we do. We look to try and identify the origin of that problem, specifically from a neurological or neuromuscular perspective. So how the brain tells the body what to do, not going the other way and trying to get the body to do something and make the brain adapt. Which is what a lot of times traditional work does. And that's not to say that's a bad thing, because like we have great relationships with plenty of PTs and doctors in this area, and without them, and you guys know who you are. I mean, Cindy, Jennifer, I mean, we love you guys. Like, they know how much we respect them, and like we wouldn't be able to do what we do without them, because ultimately they're our advisors. They're our healthcare people, and as they should be. Like, I'm not a healthcare person. Like, you pull something, or I mean, I don't know what you did. Don't ask me to tell you what you did. I don't know. Go see Jennifer. Go see Dr. Hood. Like, that's go see your ortho. That's not what I do. Let me know what's going on, and then we'll address it from a neurological side of stuff. And then if you need to treat symptom side, then that's for a PT or healthcare provider to do. But, when you get into Dr. J stuff and, the importance of what Doc did, and for anybody who's been listening to our show for a while, I always refer to him as Doc. Dr. J, there have been some people on our podcast already, and every single one of them we have great relationships with, and I'm very honest in saying, like, how much I appreciate them, and they impacted what we do, for sure. Dr. J is special in the sense that Dr. J changed everything that I thought I knew. Dr. J changed the game. And he doesn't do podcasts, but we do have a pretty cool announcement in telling you he is going to be joining the starting block, and that episode will be coming out in 2023. Dr. J and I have a great relationship. He's a brilliant, brilliant guy, and his methodology created a storm across the internet, like when the internet first came out, right?
Right.
Yeah, it's almost like when Al Gore invented the internet. You young guys won't understand that. And Dr. J, I think was, at least in the mainstream side of it, was one of the first ones to kind of address that input in neuromuscular, neurological standpoint. I remember when I went up to go visit him, Elliot and I drove up there, and we drove up in Elliot's little 1984 like Nissan Maxima. There was a hole in the floorboard, like the thing was shaking the whole time. Like we drove up there because he went to go see Dr. J, and I remember Doc came over to our hotel one night, and we were going to go out and go eat some dinner, and he grabbed one of my at the time my NASM PT book. And he's like, "This is shit," and just threw it across the room. And I was like, "All right, okay, I like it." And I walked in his office and it changed my life. Like, it literally changed my life. And so I'm kind of getting off track there, but it really is just a different perspective. And so, when people ask, "What's the difference?" Well, the difference is evaluating how the brain is telling the muscles and body what to do. And what we do, like I don't do square one. And, Sean came on, and I love what Sean has to say. And Chris, I know you do. You've shown me a few things, and I think it's great because I see responses. I see things that correlate to it. We look at it maybe a little bit differently, but ultimately it's all the same thing. It's just influencing the neural integrity. So clearing out interference in the brain to help the body do its ultimate job. And I think that gets confused with be activated and RPR a lot. And, I've seen that where I put some information out there. I put posts out there and people will be like, "Oh yeah, you're doing RPR." No, I'm not. I don't do RPR. I do be activated. I actually trained under you. You taught me how to do be activated. So we did be activated when it was still be activated before Corfist and Cal Dietz and them, took over and changed it to RPR. And if you do RPR or you find a practitioner who does RPR, it's a great service. Like it's a very good system. 100%. I like it. And we use basically the same thing at times. But that's different than doing something like our system that we work with under Dr. J, or I'd probably say even Square One, And Mandy and I were on a podcast years ago with I don't know how to put his name out there. I don't want. I mean, we got a good relationship. I hadn't spoken to him in years, but I think there was when that podcast came out, they asked me about RPR and be activated, and I made some comments, and I still stand by them today. But I think it kind of put a taste in people's mouth of like, oh, hey, I don't like be activated or RPR, and no, that's not the case at all. I think it's a very useful tool, and it's useful for any practitioner because it still can influence the body and tell it what to do. But I think it's kind of like taking the kink out of a hose rather than addressing an even deeper rooted issue. And that's where I think Dr. J's work, and I think Square One, really come into play.
So if you think about it in these terms, I mean, some of these systems and some of the inputs don't even require a practitioner of any sort. You heard.
Right.
And by the way, you already mentioned that Dan Fichter is going to be a guest on the podcast. We may or may not have already interviewed him at this point. But some of the things that you can do to influence your own input, changing how your body interprets the input, you can do without any practitioner whatsoever. It's a little harder to evaluate yourself, but people know I do this, I don't hurt, or I do this, I run faster, or I do this, and whatever. I jump higher, I throw the ball fast, whatever the case may be. Those things are pretty easy to evaluate. And so did all of a sudden this weird little, hey, I turned both my feet to the right, and all of a sudden my hip pain went away, whatever. That's real, and so that's that. By the way, that does not mean I'm telling everybody with hip pain to go lay on their back and turn their feet to the right. Okay, but it's just something to point out that simple changes in the way your body perceives sensory input changes the output, and without input there is no output. And I think that is once again where you're going to see the changes in between whether it be physical in your physical therapist's office, whether it be at elite level performance, whether it be with me, whether it be with a chiropractor, whether it be with a square one practitioner, I don't care who it is. Someone who addresses that first and then addresses the output end after addressing the neural input end is going to end up with a much better long-term result. Period.
Agreed. And that's I reiterate that. I say that all the time. I say that all the
Reduce
time. I mean,
the threat. Reduce the threat. And it's not even for pain. It's also for performance. So anyone who thinks you have to be injured or you have to have pain in order to benefit, that's not true. If you have any kind of a limitation or any kind of something where you're stuck, it could very well be a sensory input issue that can be addressed and improved on in minutes in some cases.
Yeah, and I mean, it's putting the body in a position where it's working for you and not against you as well. And people will come in and they'll ask me, oh, well, should I still go see my chiro, or should I still see my doctor, or do I do PT? And my response is always, look, I'm not answering that. Like, yes, do what your doctor and healthcare providers tell you to do. I'm not here to try to replace what that is or what you're doing. What we do can help assist that, because we evaluate things from a little bit different perspective. We evaluate it from eliminating those threats. We evaluate it from getting the protective mechanisms out of the system, and that subsequently influences anything you do on that output side. So if you're having trouble, if you're recovering from an ACL, that's a common one, right? Recovering from ACL. Well, look, I'm not going to try to take you through your first 4 weeks of rehab. Like that's not what we do. No, what we do though is if those muscles are shut down, which they're going to be, because arthrogenic inhibition, okay, the brain moves away from the joint area, try to protect it, muscles shut down, blah, 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 it's surgery, your body perceives a threat, okay, so it shuts things down, right? And so by creating an environment where you clear out that threat, the body can do its job, the muscles can do its job, that requires zero loading, zero movement, nothing, whatever, that's all something we do on our end. You have now placed that individual so far ahead of the curve, because what would have taken traditionally, 3 months to work, now it's all of a sudden firing, and that just helps assist their recovery, and it assists the practitioners, the healthcare providers, in their work, and so it all just works together. And I think you're starting to see a change in that across the fields. I notice there's a lot of doctors and PTs around the area that are opened up to us. They've reached out to us, and it's great. It's rare because it's not an ego thing, man. Like I don't need any recognition, man. You and I, neither one of us do. This is about improving our community and trying to get all of us to work together and to bridge that gap. And so I keep preaching about this forever. I know, Chris, we got to wrap it up.
No, absolutely. It's it ultimately comes down to the benefit of the athlete, the client, the customer, and it's anybody who thinks they got all the answers, chances are they are the ones who know the least. And certainly we, I'll admit, I mean, I don't know anywhere near all there is to know, but
no, it's a Dunning-Kruger effect.
Yeah, Dunning-Kruger, yes. Anyway, it's if we can all kind of put our egos at the door for the benefit of the people that we're serving, I think we're going to be in better shape.
Yeah, 100%. So we'll probably do a follow-up to this episode, because I think we can go a little bit deeper into how it all works together and some of the areas that we look at a little bit more specifically, because Chris and I do a couple of things differently, but a little bit more specifically and break it down. So we're going to wrap that up for today. It's a little shorter than normal, but remember, guys, that we ask that you please share the show. If you got some value in this, if we gave you some information, please share it. Please put it on social media. Please tell a friend, a family member, and bring them to our show. like I said, our goal is to help the community, and we just want to continue to improve our communities and help you guys win. So appreciate you. You can follow us all on social media and send us your questions if you got them. And
All right,
we will
guys.
see you guys
Thanks.
here soon.